Okay.
Hi, my name is Dr. Muteeb Ashraf. I am one of the gastroenterology trainees in Conquest Hospital. Today, I am presenting a very interesting case. Let me share my screen first. Presentation, I will start with the case presentation. And then I will talk a bit about Ehlers-Danlos syndrome and how to diagnose it. Then I will talk about Ehlers-Danlos syndrome and GI involvement, um, abnormal GI physiology and organic GI disorders in Ehlers-Danlos syndrome. Then I will talk about differential diagnosis, investigation, management of severe chronic small intestinal dysmotility as per the PhD guidelines. This patient, 28 years old female, presented with long-standing history of non-resolving nausea and vomiting, likely secondary to Ehlers-Danlos syndrome-related gut dysmotility. She was diagnosed to have EDS a few years back. How to diagnose Ehlers-Danlos syndrome? I will wait for your responses. So option A is skin hyperextensibility, B is wide and atrophic pressurious scars, C joint hypermobility, D soft puffy skin, or E all of the above. The answer to the question is E all of the above. I will talk about it in detail later on. For now, we'll continue with my case. So this patient's past medical history includes unspecified airway disease, and she was under prompt and respiratory for that, chronic respiratory failure, obesity, hyperventilation syndrome, perineum syndrome with the previous facial reconstruction, bipolar affective disorder, borderline personality disorder, migraines, Ehlers-Danlos syndrome diagnosed in 2016 on the basis of high Beighton score and skin hyperextensibility. This is the medication list. She was allergic to penicillins. Family history was insignificant, and she was a non-smoker and non-drinker. Presented in May with the nausea and vomiting, and her relevant investigations were bloods were unremarkable. Gastroscopy showed 2 centimeter hiatus hernia and no other pathology found. CT abdomen was nil acute, and MRI head was nil acute as well. Investigation will you consider next in this patient? So option A is manometry, B pH study, C barium swallow, D gastric emptying studies, E ultrasound abdomen. So for this patient, we requested gastric emptying studies when she attended a gastroenterology clinic in October 2019. In November 2019, the results were back, which showed delayed gastric emptying, and she was started on a prokinetics trial with some benefit. The patient decided to move to Southern Ireland, and where she had 11 weeks admission with recurrent vomiting and requiring NG feeding. In January 2020, she moved back to England. She had a hospital admission with vomiting and abdominal pain. She failed trial of prokinetics. She was discussed in MGM, and the plan was made to refer this patient to neurogastroenterology team in Royal London Hospital for query dysmotility secondary to EDS. She was started on an NG feeding, which she tolerated well. She was discharged with advice to get her NG replaced every 6 weeks and follow up with the neurogastroenterology team. Fortunately, she presented again in April with a blocked NG tube and that needed reinsertion. 4 reinsertions in 4 weeks. Then in May 2020, admitted to the hospital with edematous abdominal pain and associated displacement of NG tube. Gastroscopy was carried out with replacement of the NG tube. There were no concerning features on OGD. We tried to expedite neurogastroenterology appointment, but it wasn't successful, secondary to this COVID situation. In June 2020, she admitted again with blocked NJ requiring placement. She was discussed again MGM, and surgical jejunostomy was performed at the end of the month. In August and October, she had hospital admissions with right foot cellulitis and paracetamol overdose. In November 2020, she presented again with abdominal pain, pain around jejunostomy site, was complaining of feeding, was complaining of pain during feeding and regurgitation of the feed back from the tube. She was discussed again in MGM, and surgical it was noted that surgical jejunostomy tube was broken, which was replaced by the IR. Meanwhile, she was started on an NJ feeding. In December 2020, she presented again with the same complaints of pain, abdominal pain while feeding, regurgitation of the feed. She was discussed again in MGM, and jejunostomy tube was manipulated by the interventional radiologist, but still she was complaining of the pain while feeding. The last patient was started on TPN, and she was intermittently on TPN in these episodes as well. So ultimately patient was referred to St. George's for long-term TPN. Which is the most common type of EDS presents to the gastroenterology clinic. So these are the following options. I will wait for your responses. So the answer to this question is A, hypermobile type EDS. Ehlers-Danlos syndrome is the term used for a group of genetic disorders of connective tissue that are characterized by skin hyperextensibility, joint hypermobility, and or tissue fragility. The overall frequency is 1 in 5,000. Pathophysiology involves inherited alterations in genes affecting the synthesis and processing of different forms of collagen. Some patients with EDS have symptoms suggestive of involvement of autonomic nervous system, and the most common of these is postural tachycardia syndrome. Diagnosis is made clinically based upon family history and physical examination, major criteria along with any minor criterion, or it can be made in the presence of the major skin criterion and either generalized joint hypermobility and or 3 or more minor criteria. My major criteria include skin hyperextensibility and widened atrophic papyracous scars with poor wound healing, joint hypermobility. Minor criteria involves soft skin, easy bruising, fragile skin, molluscoid pseudomers, subcutaneous spheroids, complications of joint hypermobility, epicanthal folds, hernias, and a positive family history. Batten score is used to assess the joint hypermobility, and a positive Batten score for adults is 5 out of 9. Diagnosis can be confirmed by DNA sequencing of COL5A1 and A2. Patients who fulfill that clinical criteria should be referred to the clinical geneticist who may order the testing for confirmation and genetic counseling purposes. Connective tissue is present in the digestive tract and around the nerves and is essential to the passive mechanical movements and plays a role in gut sensitivity as well. Patients with EDS can present with both structural problems and as well as functional problems such as disordered gut motility. Most common presentations are delayed gastric emptying, causing nausea, vomiting, heartburn, abdominal bloating, constipation, diarrhea, functional GI disorders such as functional dyspepsia and irritable bowel syndrome. In one of the studies carried out in 2015, it was found that 37% of the patients with the diagnosis of IBS meet the criteria for hypermobile type of EDS. Results of gastrointestinal physiological studies were reported in a retrospective observational study from the Mayo Clinic in EDS patients of whom the vast majority had hypermobile EDS. The study was carried out in 2015, and it was found that 28% of the patients who underwent colonic transit studies had abnormal results. 60% of these patients with abnormal colonic transit had hypermobile type EDS. 22% patients had abnormal gastric emptying, and 31% patients had abnormal esophageal manometry, and 44% patients had pathological acid reflux on reflux testing. In another study in 2010, the study was carried out on 21 hypermobile type EDS patients in Italy. 87% of the patients were found to have GI symptoms, most commonly dyspepsia, followed by recurrent abdominal pain, gastroesophageal reflux disease, alternating constipation, and diarrhea and abdominal hernias. There are some studies that associate ADS with the organic GI disorders as well. The first was performed in a Greek hospital setting in 2009, which described that the prevalence of hypermobile EDS in Crohn's disease was higher than in UC, 12% and 3.6% respectively. But this difference was not statistically significant. Another study in 2015 also demonstrated a relatively high prevalence of joint hypermobility syndrome in Crohn's disease and ulcerative colitis patients, with 32% and 21% respectively. And another small study in 2011 demonstrated a high prevalence of celiac disease in hypermobile EDS patients. 31 patients attending a genetic clinic with an established hypermobile EDS diagnosis were screened for celiac disease, out of which 19% were tested positive, and duodenal biopsies from 5 had features consistent with celiac disease. The prevalence of celiac disease is 16% in a hypermobile EDS group, was therefore significantly higher than the estimated population prevalence. So what's the differential diagnosis in a patient with whom we are suspecting gut motility disorders? There are a few of the conditions that can mimic gut dysmotility. Organic obstructions, sometimes small bowel volvulus from a band adhesion or interception, radiation-induced adhesions from previous abdominal surgeries, opioid and other drug effects on the bowel, cyclizine, anticholinergics, calcium channel blockers, and antidepressants. Functional GI disorders such as IBS, functional dyspepsia, cyclical vomiting, functional blotting, distension, functional constipation, diarrhea. Psychological, psychiatric problems such as anorexia nervosa, restrictive eating, psychiatric disorders, and psychological distress. And there are sometimes effects of the undernutrition of gut function and hypermobile type EDS. Published guidelines on the management of severe intestinal dysmotility in adults in June 2020. And as per the guidelines, it has myopathy and neuropathies. This is a long list of classification. I will not go into the detail, but they have classified in myopathies further into primary and secondary, and neuropathies into primary and secondary. You can have a look. So as per the BSc guidelines for the management of intestinal dysmotility, these are the following investigations that should be considered in a patient with dysmotility. History and physical examination are very important in guiding us the investigations, and we should focus on family history and foreign travel. Family history can suggest us about any connective tissue diseases, and foreign travel can suggest us any Chagas disease, any We should determine muscular diseases, neurological diseases, endocrine diseases, and history of irradiation and connective tissue disorders, and lying and standing blood pressures if there are some autonomic involvement as well. Blood tests to exclude hypothyroidism, celiac disease, diabetes, scleroderma, and other connective tissue disorders. Chest X-ray, CT, or PET for thymoma and other neoplastic conditions. Manometry, PS studies, gastroscopy, colonoscopy, stomach emptying studies, hydrogen breath test, barium swallow, colonic transit studies, proctography, input thickness, jejunal biopsies are recommended by the PST guidelines. So in the management of these patients, multidisciplinary team approach should be considered, as these patients are complex with multiple issues. And the team is likely to include a gastroenterologist, intestinal physiologist, GI surgeon, pain team, psychiatrist, psychologist, rheumatologist, urologist, gynecologist, radiologist, dietitian, specialist nurses, clinical biochemist, histopathologist, and pharmacist. Patients are often treated symptomatically. It's important to treat the underlying condition. Diet-based interventions have a role in the management of the system and the management of these patients as well, such as low food diet is frequently used to good effect for abdominal bloating, pain, and diarrhea. Enteral nutrition via nasogastric and feeding, percutaneous endoscopy, gastrostomy, jejunostomy feeding, and if enteral route is not available, then parenteral nutrition is another option. Surgical interventions to treat the significant dysmotility by bypass surgeries and enteric resections, neuromodulation, and last but not least, psychosocial aspects should be sought and should be treated as well. These are my references. Very much for attending, and special thanks to Dr. Stephen Fong and Dr. Mike Whitehead for giving me the opportunity to present today.
Okay, thanks very much for that, Muteeb. So that's a very helpful illustration of actually a real case of a very tricky chronic intestinal dysmotility patient. I think the main mistakes or lessons I've learned from these patients is, number one, they're quite complicated. We are seeing a lot more of them in Conquest. I'm not sure what the exact reason for that is. And what you have to learn is that it is tricky trying to find what we would say an organic cause for their conditions. You end up having to do quite a large battery of tests, and that can be very confusing and tricky to manage. So it's quite useful to know that the BSG under Dr. Jeremy Nightingale has recently published a guidelines on the management of chronic intestinal dysmotility. And I would recommend as gastro trainees that you have a look at those guidelines, because it does give you a nice system for what sort of tests you should organize and the kind of management options. It is worth saying, though, it's still very tricky. A lot of these patients may have difficulties with pain control, cyclism. So it's important you have a MDT approach and you involve a senior who's quite experienced in these kind of conditions too. So a quick question to you guys. Hands up if you've dealt with a EDS related severe gut dysmotility case. Good. Christine, I know you're based in Eastbourne, so if you don't mind, I might just want to ask you a few questions. What sort of problems did you find difficult about the EDS case you were dealing with?
Mine was not at Eastbourne. Sorry, can you hear me?
Yeah, go ahead.
Mine was not at Eastbourne. It was one of the previous centres I worked at in Derby, and it was quite a complicated lady who it was very much communication and trying to make sure that we were all giving a very unified approach with, particularly with her pain relief, and had it was very much trying to work with the family dynamic.
I think it's normally they come hand in hand, don't they? We had one EDS patient who was in hospital with us for 4 years, actually. It was extremely difficult to manage her multiple different problems, not just nutrition, but pain control, leg problems, and family dynamics. She ended up having COVID and passing away, sadly. So this is a very difficult group of patients. I'm just curious, the EDS diagnosis, was that made? Did you involve a specialist for this patient in Derby?
That was quite difficult. So her and her family had gone to a previous rheumatologist somewhere very different, and then presented and said that they had this diagnosis, and trying to get to the bottom of where that had come from had been quite difficult, and they were demanding certain medications because they said they had this diagnosis and that's what they were told that they could have, which obviously then made the doctor-patient relationship slightly difficult.
Yeah. That's a big problem we have, is normally you guys will inherit these patients from a different unit. So you sometimes also end up having to decide if the diagnosis is correct and whether you have to repeat some of the tests or do some new tests to make sure you're not missing something. On top of that, like you said, there's the family dynamics. And the second question is, are you confident enough to make a diagnosis of EDS? And I think a lot of people, even me when I started as consultant, had some difficulty finding out who to go to. I mean, for me, down at the Conquest side, if I have a tricky case that I need a bit more clarity about the EDS diagnosis, I might refer it to Asma Fikri at the Royal London Hospital. And I believe there's also another specialist at UCL. And some people do refer to Anton Emmanuel. So I think one thing that can help you is trying to find out who perhaps is the right person to refer to for EDS in your locality. Dom, I think you put your hands up too. Did you have any particular issues with your case as well? And Robin? That's fine. Sorry, you're still on mute, but go ahead.
Yeah, so it was at Margate Hospital. We had someone with EDS, essentially with a lot of abdominal pain and difficulty eating, and not being able to keep food down via the oral route. And so I think eventually we went for a peg with a jejunal extension, and that seemed to calm the patient's symptoms down a bit, but she was still quite difficult to manage, and it was mainly a sort of pain control issue, and most of the objective tests were a little limited. So it was a bit difficult, again, managing the patient as a patient more even than the disease itself.
Yeah. So it sounds like you guys went for a distal feeding or a PEG-J, isn't it? So like you said, a lot of these are tricky decisions best made in a nutrition MDT. For the gastro trainees, I think Simon Lau's frontline gastroenterology paper about when to do jejunal feeding is very helpful. So that's another one for bedtime reading I would recommend, basically. But the take-home messages from that presentation is definitely read up on the BSG guidelines so you have a better structure. ADS-related gut dysmotility is increasingly more common, and it's definitely one for you to try to get a grip on. Okay. Any other questions? If not, what I would suggest is another 3 to 4 minute break. It's about 11:16 now, so at 11:20, I will put on the last case presentation, which is on intestinal failure, how to assess and manage it. And after that, that pretty much is the last presentation for this training day. We're going to truncate this so that you've got time to get back to do whatever you need to do on the wards. So just give yourself another toilet break or coffee break for a few more minutes, and we'll continue with the last presentation.